This meeting is being recorded.
Okay, our patients would be telling us that I know where it hurts. It does hurt here. It just hurts. I don't know where it hurts. And I would have an idea that, yeah, it's probably the kidney that's not functioning, or that's the kidney that is causing trouble. But if a patient says, yes, this point hurts, then I would know that it's probably a musculoskeletal origin instead of a kidney origin. So if I use this one, can everybody see? This is our vein, right? And then this is our renal pelvis to the bladder. All right, see? Not sure. Okay, all see this? Right. So probably we need a thicker Sharpie next time. So, can everybody? Take kind of that. Okay, wonderful. So, this is our kidney. Our kidney, the function of our kidney is to make blood in your the urine down from the kidney, the pelvis, to the ureter, and then to the bladder, and finally excrete the urine, okay? There's something, a stone, it could be tumor, that obstructed in this passage. What happens? Urine cannot come down, it will go back up. What all? Formation of the urinary system, of the collecting system. The whole thing would be dilated. We call a hydronephrosis. What we call hydronephrosis. I love Latin. Does anyone like Latin? I know enough Latin. I only know Latin from the medicine field, but I love Latin. Hydro, water, nephrosis, extension of our collecting system. So there's excess water in our system, and when our kidney is excited with urine or fluid, the fascia, the cell doesn't have nerves, but the fascia has nerves. So the nerve fascia, and it will tell you that you're hurting. It hurts everywhere. It hurts at this flank area, but not at just one pinpoint. So how kidney stones cause problems. And a lot of urine backed up in your collecting system in your kidney, it will also affect your kidney function. So this is for us to drain. They said they not either red marker. All right, then I won't use the red marker no more. The blue one. I hope the blue one is better. Better. Wonderful. Okay. Hydronephrosis, and this is the dilating of the college. Right. Okay. So our ways for us. Okay, think of urologists as plumbers, because we are plumbers. We have to work with blockage of this plumbing system. This is our plumbing system. And we have to think of ways how to deplumb this. So we have other surgical techniques to do this. So we'll go to the next slide. So order, we'll talk about treatment in a bit. What type of order? I think Abby has already had a pretty good idea. The kidney function test, the CT scan, and the KUB. Let's see what real test that we should order. Urine again, and then blood function. So all people get that right. KUB. I don't know how far extent that everybody has in the medical knowledge, but do you know what KUB stands for? Does anyone know what KUB stands for? Right. KUB, right. So why is it called KUB? Very nice. Okay. I may be underestimating everybody's potential, but forgive me because I don't know where everybody is at this moment, and I don't know. I just want to have everybody on the right track, and could be just the changes on the bladder wall. That's good. That's advanced thinking because right now I'm thinking stones alone, but bladder wall. The set of the bladder wall could be because it may have some neurological changes to the system. That's why it's causing problems. That's a very good take. Okay, now next on the slide, ultrasound to see if there's hydronephrosis. What I did here was that I take the least invasive into the most invasive part of our test. So that's KUB, which by the meaning, kidney, urinary, and bladder. And I would teach my patients of how to read an X-ray would be that the dense things, for example, your bone and stone, they will be in white. So a lot of patients, I'll tell them to show that their stones are and to give them a pretty good idea of how they are. Because I want the patients to really know what they're doing and what's happening to their body before I give them any treatment. I want them to also be in the treatment with me. Next, the kidney ultrasound. And so the kidney looks like this on the ultrasound. It's here. So the ultrasound would come from here, okay, the ultrasound. The beams would come here and the kidney lays around here. And water on the ultrasound is hypodense. It's dark, okay, so this is water. In this scenario, the parenchyma would be a little bit dark, but the collecting system would be a little bit white. On this case, where you see on the ultrasound, that there is darkness here, as shown this ultrasound. So that means there is a backup. There is an obstruction somewhere along this passage that causes the kidney to be obstructed and to have hydronephrosis. So this is what I'm trying to show. Next. So treatment. Click. There's location, there's the size and the symptoms and signs. It depends on where the location is, the size, and the symptoms and signs. Like I said, we are plumbers. So there are ways of, okay, come on. So there are ways to, it all depends again on the location, the signs, and the size. You continue. Where the stone is. The stone, the location of the stone is just as important as it's just buying a house. It's a location. So the location of the stone is in Sydney. There is really nothing. It indicates that there's really nothing you can do except you can do an asphalt. That's an extracorporeal shockwave therapy. I'm only throwing things out. I know this is a lot of information. This is only a bird's eye view of urology. So to have a brief idea after I talk, you don't need to memorize everything because these are too much of a detail. Options of an asphalt, a PCNL, and there is a retrograde flexible where we have a flexible scope in here and then use the laser to blast this off. There is also, if it's stone in your ureters, that can use what we call like a uroscopy. We can go in, and it's called uroscopy lithotripsy. Lithostone. Trip is blasted of it. So we can go all the way in and use laser power to blast this open, and so it would be declogged. So these are surgical options we can do. Okay, and this of recurring with it. Well, I saw that on the question. It really depends on one size of the stone. If there's any remnant of the crystallization, it could have more crystals in the future. But how far into the future? It depends on the patient's diet. It depends on patient's fluid intake. Say mostly our patients that are seeing the cycle of recurrent stones is about 3 to 4 years. Every 4 years, there may be another occurrence of stone obstruction if you already had the first episode. So that's me answering your question. I don't know if that's not for your answer. Okay. I continue. I'm continue. Okay. Next slide. Okay. I found this slide, which is I think it's pretty cute. If you like a background, this is like again a really nice bird's eye view of stones or urociliasis. So the background contributing factors, a lot would be more dietary and fluid intake. Less of prevalence would be due to hereditary or metabolic problems. The renal pelvis, because it's in terms of symptoms, if it's in the renal pelvis that is in a larger area, it doesn't cause any obstruction, there's no symptoms. Or if it's buried in the parenchyma, it doesn't have any symptoms. With stones really causing a problem, when it's down to a more narrow place of our collecting system, that's when it causes a problem. Okay, type stone. The two, number one and number two, are calcium oxalate and calcium phosphate. Now, I have a question for you. What stones do you not see in the UV? What of the stone that's radiolucent? That means you cannot tell, you cannot see this nice white round thing. From anyone have any idea? Uric acid, wonderful. Very good, very good. And what else? Is there anything else? Now, like, that's a common type of radiolucent stones. But the other stones may be like a cysteine stone or dancing. Very good. Oh, I see cysteine stones on the class. Okay. Everybody, you are awesome. All of you are so good in responding. So what I remember from back in my medical school days is that, radiolucent. I'll write it here. Radiolucent. There's a pneumonia with the lu, which is uric acid. That's how I remembered it. It's probably not helpful since you guys are all so smart already, but how I remembered it back in my day. All right. Treatment, like I said, there's the medical treatment and there's just surgical treatment. Control, has mentioned it, that's wonderful. Also, hydration is also a very important factor. You want to wash the stone down. The stone is less than 0.4 centimeters. You have a 90% cell passage. So we encourage fluid. So if the stone is less than 0.4, we won't do much about it, but we will tell the patient that we'll follow you up in a week or so. And at this moment, please drink a fluid and not beer. Because sometimes we drink a lot of beer instead of water, and it's not due to drugs. That's a medical expulsion therapy. That's why will give alpha blockers in patients to relax the smooth muscles in the ureter and the lower ureter and the bladder, so it will encourage the stone to be. It would come out by itself. And uteroscopy, that's what we talked about now. So I think there's a pretty good slide. I found it. I forgot. Oh yeah, that's the reference. So it's a great slide. I hope you find it useful as well. Okay. Now this is another clinical of our section. So is a 2-year-old female saying that I leak my urine pull my down. It's been last year, but it's just getting worse. Okay, I not get out the house because I pee in my pants all the time, and I don't walk faster anymore because urine will come out, and I would smell of pee, and people don't want to see. I'm more withdrawn. I can't go out the house. I mean, yeah, it's like pre-pandemic days because post-pandemic everybody's just inside the house. Still have to think of ways to improve patients' life. Here we go. Incontinence, wonderful. That's it, very straightforward. Very good. Okay, now next. What would you order? Again, well, the diagram over there kind of gives it away. Okay. Anyone give me any feedback? I just go drink some water and hydrate. That's not next. It's good. I'm not urine analysis. Yes, everyone is getting like the hang of this. Yeah, I don't have much. I don't have not that creative. So UA, ultrasound, and bladder stress test. Okay. Hi everyone again. I'm allowed to take off my mask. Less than 5 people in the room, and we are practicing a good social distancing at this time. So I can finally take off my mask. Hello everybody. I'll see all of you, but too bad. Function test, that's wonderful too. Stress test, that's interesting. Okay, for all your feedback, if you have any more, just keep it coming. So fully ordered. Yeah. Right. Big surprise. UA. Okay, next. Another KUB, because we need to rule out the chances of renal stones or bladder stones. Could it be an irritative cause, right? Next, post-residual. That's sort of like a urodynamic study is warranted. And that diagram over there, that is what we call a urodynamic study, where we would put catheter into the rectum, we'll put these into the tummy, but in the rectum or the tummy, you choose one. A urinary catheter, and then we would simulate a scenario where your bladder is full, so it asks the patient to tell us when they feel their bladder is full and when they want to pee. So we'll get first urinary sensation, the urgency, how the bladder is filled, for the patient to feel a sense of urgency, and then bladder capacity is the largest that they can hold. And we would ask the patient to void so that is the detrusor, the bladder muscle, contracting or not. And the sphincter of our urinary system is opening or not. So this study would give us a good idea of what happens in filling and voiding. Okay. Right. So let's say incontinence, but there are types of incontinence, right? So these are the types of incontinence. We have stress, urge, mix, overflow. What I think I've done this one. There are mainly four types of incontinence. We have stress, all right, stress in incontinence. Urge. I'll draw out four bladders for you to have a better idea of what I'm talking about. Okay. And then we have a mix, which is quite self-explanatory, and we have overflow. These main four types of incontinence in our study. So incontinence, this is when there is involuntary leakage of urine upon abdominal pressure. So there is abdominal pressure coming up from upwards and the patient closing valve. The sphincter is not as strong anymore. They're meant to leak urine. So imagine your bladder is like a house, and the foundation of the house is weak. So that's whenever there is like a strongest storm, your house will start leaking. It's like the foundations are weak, so that's why it cannot hold urine. Now, urge is it's like a involuntary contraction of detrusor muscles causing urine incontinence. So the detrusor just contracts on itself. It cannot hold much urine. The main function of our bladder is one, to storage and voiding. It cannot do storage. Well, all of them cannot do their storage. So urge is like this. It's mostly that the foundation is usually okay, but it's better that's contracting. It could be due to diet, again, fluid, what type of fluid, because we have that caffeine and tea with they tend to increase urinary volume, and they will tend to make the patient's void more. So due to aging, would also cause urinary incontinence because there's atrophy to the bladder, to the urethra, and the entire vaginal area, and that would cause urge incontinence as well. Now, urinary incontinence, it could be stress over urge, or it could be urge predominant, or it could be stress predominant, or they can be equivalent. We treat them as their symptoms. Stress and urge has a different treatment system. Overflow incontinence, which is mostly due to BPO. This is when bladder is filled with fluid and it cannot take any more fluid and it just flows out by itself. The bladder cannot contract, the sphincter cannot close. It's just a haywire of things going on in this bladder, and which cause overflow incontinence. The treatment of stress and urge urinary incontinence are as follows. Stress incontinence, we have to fix the problem. We fix the foundation. So what we do is that we would give another supporting system to this urethra to stop it from leaking urine. So I don't much have you know the surgical treatment of stress urinary incontinence, anyone? Any idea of how to treat urinary incontinence? Have you ever heard of it? Anyone? P and POT. Okay, so there's POT. And anything else? Anything else? Mainstream of your incontinence treatment. I wonder if I could use this area. I can come and use this area. Procedures. It could be POT or TVT. So treatment for stress urinary incontinence, it constitutes PVP, protein, or in cases autologous slings, which we would take a little bit of our rectus fascia and to use it as slings, because we know that these two, they are artificial materials. And if the patient has an issue of previous sling procedure complications, we could use a little bit of the rectus fascia and act as a sling, and it will act as a support. So what happens is that, so this is our vagina. And it's having the, this is the bump. Okay, so the DVT is going through a retropubic root. It is going through a retropubic root, retropubic. We find the bone, find the bladder, and the tension would be tension over here. Why? TOP is obturator foramen. Does this ring any bell, the obturator foramen? Anyone? Everybody's on anatomy, but this is the obturator foramen and the central obturator. Sling with retropubically, it would go here. Obturator foramen. Does anyone all remember this? Does anyone remember where the obturator canal is? Anyone, if you can see, okay, the obturator canal, there's A, B, and C. Where is the obturator canal? Can anyone see? So between pubis and ischium. Okay, good. Where does the nerve out from? Let me rephrase. Where does the nerve and the arteries come out from in this obturator? Okay, and I tell you it's B. So I have a magnification glass of the obturator foramen. This is inside. This is lateral, and our pubis, the urethra, and the vagina. Okay, the sling would go out from here. So during surgery, after we open the vagina of the anterior fascia, we would back this root and have the sling hugging the bone and come up here. What we do is area, which is there is a 2 to 3 centimeter width, this window. So that's why we have to avoid this area with the TOT procedure. Just a little view back to anatomy, so P versus PVP. You guys have, have you seen the surgery before? This is a pretty excellent surgery. Yeah, so this is the treatment for, so stress urinary incontinence is a surgical treatment. There's very little medical treatment that could help with this procedure. And on the other hand, urge urinary incontinence is not a surgical treatment. It is more of a medical treatment, which I will guide you through this. And as I said, I promised that I will go pharmacology, and I'll go back to a little bit of anatomy on this one with everybody. So I would need everyone's participation on this. I use this side of the board. We follow to this side of the board. Okay. So where brain the controls and which part of the brain is responsible for voiding? Anyone? This is our brain. This is our spinal cord. There we go. The brain. Anyone? I wonder why I keep on time. So what we call it is Pontine Maturation Center, the PMC, which is responsible for voiding. Therefore, this is Vivian. Is it? Thank you. Thank you for participating in my question. And people know as well, but probably we just been a lot faster than others. CMC, this is where we control our voiding in the spinal cord. And we have our bladder right here. A little more. Okay, so our is innervated by the sympathetic and parasympathetic and the nerves. Yeah. Here, where on the spinal cord, it has to innervate the sympathetic nerve. It's which spine, which level to which level? Does anyone remember? I'm sure the big lag in our connection right now, right? Yeah, there's a big lag, so I'm just going to tell everyone. So the sympathetic nerve comes from the T10 to L2. Very good, very good. T10 to L2, I see you. Thank you. And sympathetic, anyone, ideas? Where does it come up from? That's responsible for innervating our bladder. I'm going to cry. Who is this? Oh, thank you. S2 to S4. As well as the somatic nerve, S2 to S4. Does anyone remember their name? This is coming out from T10 to L2. Do you remember their name? As we're innervating our bladder. Anyone? A little hint would be, it starts gastric nerve. The parasympathetic is lymphatic nerve, but the somatic, you're right. Somatic is the pituitary nerve. Okay. We're on this topic. I'm sure everyone here is 18 years old and above. So do you remember which urine and ejaculation, who is responsible for ejaculation and who is responsible for erection? Is it sympathetic or sympathetic? Okay, let's say who is responsible? Erection, parasympathetic. Okay, and anyone else? Oh, I knew there was a big lag from the chat because I know that every one of you knows. Okay. There's this mnemonic back in my Bible today. I hope you don't find it offensive since we're all talking about medicine. So the point and shoot. Erection, and that's parasympathetic. Angulation, and that's the sympathetic. That's one of you read it this way, but that's how I remembered it. And true. And also and for the nerve responsible for erection. There's a mnemonic if anyone is interested would be S2, 3, 4, keep your penis off the floor. So S2 to S4, responsible for erection. Okay, I'm going to carry on. So that the bladder and the nerves and our bladder. Our detrusor muscle, this little mushroom, and the urethra is covered with tricep muscle on it, it has a lot of muscarinic receptors. And to the bladder, there's muscarinic 1 to 5, right? And what about on the bladder? Does anyone remember which muscarinic receptor is more predominant on the bladder? Wait. Does anyone on this part? And it will be M2 and M3. Right? Okay. And also on our bladder, it also has the beta receptors, and in the bladder neck and the ureter, it has more of the alpha. So this is where the receptors are located. And back to sympathetic nerve, fight or flight response, right? Do you want to pee or not to pee in here? To pee, right? And if we want a patient to void, we would use alpha blockers to block this out or to pee. So why in eyes of the BPO, they are blockers. So they end with a lot of sodocin. Sodocin, tamsulosin, silodosin, alprazosin. No. So this is where the medication comes from. Urinary incontinence, or what we call like an urge incontinence, it's recent incontinence. But there is a situation where the bladder is contracting itself, but without incontinence, what we call OAB, overactive bladder. So the medications that's treating overactive bladder, they work on these receptors, the M2, M3, and the beta receptors. The M2 receptors, so this goes to the parasympathetic nerve. So what do we want them to do? We want them to, so in here they pee, right? We want to use antimuscarinics because in OAB patients, we want them to stop voiding, stop peeing. So we would block these M2, M3 receptors. We use antimuscarinics such as the solifescin, oxybutynin. I'm not quite sure what we have in Malaysia, but these are like the big categories of antimuscarinics. But what's the biggest issue with antimuscarinic medications? Does anyone know? It's not a, it is a lot of side effects because muscarinic receptors is static within our body, and if you block it and it's not very highly selective, it will affect all the other organs such as the saliva and the GI secretory glands. So that it would have side effects such as dryness in the mouth, constipation, or blurry in the eye. And what worse is sometimes they would travel through the BDD and a patient's cognitive function. Our urge urinary incontinence, correct, in IOP. Because our urge urinary incontinence patients, they are mostly 65 and above. It could be 70 something. They could be in their 80s or their 70s, and we cannot risk them as cognitive impaired. They're already on so much medication now, and having more antimuscarinics would really mess their life. So antimuscarinics should be used with caution. Especially, you need to see what the patients are on and to avoid any drug-to-drug interaction. So the time of 2015, 2014, there is another new drug that plays with the beta receptor, and specifically, it's S3 agonist. The commercial name is called Mirror Background. well, that's not the commercial name. Commercial name is another. So neurobackground is the best-free agonist, which is more specific on a theta. And theta is off the sympathetic nerve, so it's not to peak, so an agonist that can be used in overactive bladder. So this medication, since it's not an muscarinic receptor origin, it does not have the side effects of all the other anti-muscarinic receptor inhibitors do have. And this is a relatively safe medication for a lot of geriatric patients. So, like, I'm going to come back to pharmacology. This is in urology. Another bird's eye view. Okay, let's go back to our slide. Okay, treatments and medical treatments, like I said, the urinary incontinence and muscarinic beta-3 agonist and the stress urinary incontinence, that's mostly like a surgical disease, which we use PDP or TBPO, autologous fascia, or bulking agents. Bulking agents does not have much of, it doesn't offer too much of a benefit in terms of cost because it's very expensive and it does not work on everyone, and you need to refill them every once in a while. So, voila. So we're going to take a mini break now, if that's all right with everyone. I think all of you must be a little bit tired, and we'll come back to this clinical vignette in a bit. So we'll take 5. I'll take 5. See you guys all in a little bit. Have everybody back. Do you think 2 hours talking to 2 hours lesson, is that too long for everybody? I don't know. It's my, I do virtual speeches as well, but like each speech is about 30 minutes because I have that much of an attention span for everybody. Any feedback about the duration? Also, we are very welcome to share. It's too much. If it's too long, let us know. We were just talking about it's fine for you. And then you try to talk to the camera for 2 hours, maybe. But thank you for being so patient with me and also being willing to be there for 2 hours for me. I really appreciate all of your attention. Just saying that I've never been to Malaysia. I really wish I could go to Malaysia. Boy, this is one thing I would really love to visit Malaysia. I love how diverse the ethnicity Malaysia has. It must have a lot of cultural, and it's so rich in culture, rich in history, rich in the city must be wonderful. You have metropolitan such as KL, and you have such beautiful scenery of each little island. That's what I saw from TV. So I wish one day I could visit your beautiful country. And all of you are very welcome to come to Taiwan as well. This tiny island offers a lot of food. You have heard, and we're mostly friendly people too, especially to foreigners. Again, I wish this could end soon, as all of us wish, and everybody stay safe. Let's go to urology now. Again, another clinical vignette we are also this is one of our last vignettes, so let's get through this swiftly. And I hope to interact with all of you a little bit more in the end if you have any questions. So 67-year-old female saying that I've been seeing blood in my urine for over a year. I don't care. I don't give a rat's about it, and I just don't see it. But now there are more blood in my urine. But this month it only happens when I pee. I have more from my bladder. And I told my daughter, and she brought me here. So this is another very common complaint. In elderly women, because they are shy to have their private parts examined, so they would be less inclined in seeing a doctor about it. And also, a lot of either perimenopausal or menopausal women, they're used to seeing some pinch when they wipe their parts after they pee, and they don't think it's a big deal until it's too late. So that's what happens to her. A case from one of my patients. So I ordered, again, a urine analysis, how creative I am, to the patients. And the only analysis, this is what we see in our hospital of a urine analysis, a color, pH, we see esterase, nitrate, proteins, glucose, ketones, and see blood, or if you can see bacteria, RBC, WBC, epithelial cells. So the patient is positive for a lot of RBC and a lot of WBC. So the patient can be having a UTI or a simple hematuria. We don't know, but let's see what happens. So mental studies of urology, a KUB. There are obvious stones in this one. And next, I also ordered an ultrasound. And the ultrasound doesn't seem, it doesn't have the hydronephrosis like we said before, right? The collective system, it looks kind of collapsed, it's white, and I don't see any tumor in blood tissue. that's bulging from the kidney. Right? Renal form looks okay. Everything looks just okay. So next, we'll see what happens next. So I order a fluid cytology. Okay, again, the patient does not have any alcohol or betel nut history. Whether she smokes, she said no, but everyone else in my family does. So she has a lot of secondhand smoking for 2 decades already. So she's a secondhand smoker. And all these suspicions, I have to rule out some things. I have ruled out stone. I've also ruled out infection because the patient does not have any dysuria or burning sensation in her urine. So at that moment, I excluded UTI. The thing I need to consider that is tumor. Pathology, where the patient has to leave a little bit of her urine specimen, and when we send it to pathology, they will read it for us under high power field to see if there are any abnormal cells. So this is the result. Result says it's suspicious of malignancy. Biopsy is recommended. They saw large atypical cells, and they once again with a lot of red flags saying that you should do something about it. So next. I order a cystoscopy. This is where we put a tiny camera into the bladder via the urethra, and this is a real life case. This is what we saw. If you see, we have to fill the bladder with water, and you see these core-looking things, this packet-looking noses. This is all from one single patient. What we saw is that they are growing at different places of the bladder, some big, some small, and they are papillary, and they look like things you see when you go diving, unfortunately, but they're actually vicious if you ever encounter them. Next. What I ordered was that I said we don't know the pathology of this mass, but it's 80 to 90% not a thing. It's high malignancy. Whatever that's growing in the bladder, 10 is not a good stuff. So we're going to resect it, and we're going to send it to pathology, and we'll tell you how we can take our view, okay? So this is what we did. We did a TURBT, which is a transurethral resection of bladder tumor for this patient. And if you can see the half loop, it's connected to a bipolar system, and it gives a very good resection and coagulation. We sent it we sent a specimen to pathology, and it gives us a T1. It has not invaded the vascularis layer. Next. Okay, go back to TURBT. So this patient, what we did is that because it hasn't, thankfully, it hasn't to the vascularis layer, the patient be treated with a regimen of BCG or intravesical chemotherapy installation and regular cystoscopy follow-up. But if the tumor has invaded to the muscle layer, we go a different route. We would recommend the patient either to go through neoadjuvant chemo, or we would recommend the patient to go straight to do a bladder resection. But what if we take the bladder out? What is going to be in the body to feed at a urine reservoir? We would use a segment of the ileum and then into a bladder leg, and we would do a urotomy, and the patient would be peeing out from the bag. And if the condition permits, we would also do what we call an orthotopic bladder structure, which we would put another ileum into a bowl-like, or reservoir-like, a sac-like structure, cut the ureters into that ileum, and then put it where it used to be the bladder and connect it with the urethra. a little bit hard to explain just by words, and so urology. Surgeries such as endoscopies, and there are big surgeries such as reconstruction and tumor. So if we can go to the next slide, which is our final slide. This is, I think, every department, every specialty is like a forest, a rainforest. And today we have only picked up like a leaf and to sneak peek of each specialty. And this is only like really like a bird's eye view of what we do in urology. So towards coming end of our presentation and our lesson for today, urology, I hope you like it, and it's that specialty because we have small surgeries, we have big surgeries, and we have medium surgeries. We have the medical aspect and the surgical aspect of this specialty, and we can practice in medical centers or medium-sized medical facilities, or we can have our own clinics. So it's pretty versatile, it's pretty flexible, and it's not a specialty if you're not an adrenaline junkie that will have a lot of life and death surgeries, and we don't have a lot of emergent surgeries. So the perks of urology, I hope you have kind of way or think about, maybe that's what I would do in the future. Any questions? Any questions you have? Anything at all? You are welcome to type in the chat, and I would like to answer of you. Since this is the first year, I'm going to unmute everybody. I'm going to unmute everybody. So whoever is yawning or singing, stop. One. Anyone, we have 150 people at least on the line. I would like to say anything. Everyone again and talk about tissue torsion. So yes, there are emergent surgeries such as penile fractures, tissue torsion, and sometimes stone in our department. Tissue torsion it usually happens to adolescent boys, and tissue torsion. It has a golden hour of 4 to 6 hours before it goes nephrotic or becomes ischemic. And it usually happens for a very, very sudden, sharp pain in one of the sides, and they're in prevalence. Each side is the same. I wish I can show you some photos of tissue torsion, because as we have photos of tissue torsion. What we need to do is an emergent exploratory surgery into the scrotum, and then pull them out, detorsion it, and to see if it's still viable. If it's still viable, we would save it and fix it on the scrotal skin, and if not, then we'll have to do what we call an orchidectomy. It's to take off the scrotum. I'm not sure if this is what you wanted to know about tissue torsion. Now, next, when do I know whether that's emergent or not? Whether we look at the vital signs. If it's affecting patients' vital signs, of course it's an emergent surgery. And there is like a time frame of fixing things. For example, for have a golden hour, and also for priapism, which is a prolonged erection of the it's not surgical yet until we have aspirated all of it, and blood, and if it doesn't work, we will have to send the patient to do an emergent shunt procedure. So if I have, everybody's having, okay, PVP incontinence, you have explained a female. Male patients having a wonderful, that's some other surgery that I do as well. So for male incontinence, we don't do this, but we actually have two things that we would do for male incontinence, which is another male sling or a male artificial urinary sphincter. I wish I have photos, but I don't. But with that, we don't call it a TVP or a TVTO. We call it male sling or male artificial urinary sphincter. These are it usually happens in patients post-rectal prostatectomy for prostate cancer. It's probably about 10%. Yes, I did answer Mr. Long or Ms. Long about it. Yes, it is considered as another type of surgery, but didn't have it in my slides. I have that in my other presentations, but not today. I'm so sorry I didn't prepare that. I know that would be a point of interest. Stones. Okay. Again, the location, the size, and the symptoms. Remember, that's what I said about surgical interventions for kidney stones. So, like we said here. Can we come to here? How do we decide and how do we treat kidney stones? It depends on the patient's location, size, and symptoms. So a run here is in the parenchyma. It doesn't cause anything, doesn't cause any symptoms, but it's really big. Would have like a lengthy discussion with the patient whether the patient is willing to take enough risk procedure for it, and if it's definitely if there's signs and symptoms, we'll definitely ask the patient to fix it. And size, in me, that would be the hallmark. The cutoff point is 2 centimeters. So if it's small, 2 centimeters, we would say, you know what, leave it. We'll observe it. We'll put your radar in 6 months. Okay, 6 months you'll come back and we'll reevaluate if the stone has passed or the stone has grown or if the stone has passed and have any symptoms. Again, the location, whether it's buried in the parenchyma or in the renal pelvis or it's on the verge of coming down to the ureter, we would suggest that to have prevention. So it comes back to these 3 parameters that we have to consider when we treat with kidney stones. The question for the stone out to pass in the ureter, that will be 0.4 centimeters, right? And we talk about that. And kidney stones would be 2 centimeters. Okay, line. I'm not sure if I've answered your question. Okay, 1 minute. Oh, I only have 1 more minute. Anyone? I saw just now in the interaction that some people have come to Taiwan before, and I really wish I could visit. But I hope you got the most out of this thing. I didn't expect to see everyone in here, but it's a very unique experience for me. Yeah, everybody like that. Yeah, I only see your initials. Too bad I cannot see any of you, but one day, thank you location, see. But I wonder, so where are you in the level of clinical setting? Are you a student, or are you a PGY1, or are you like a resident? I wish there were like 200 of you, but I can't. Okay, well, I'll come. I think all. And I do have an email if you guys want to contact me. Any possible, like where do you come to look for good food or like good drinks or good places for sightseeing or anything urology related could be too. It would be Dr. Yang yang.uro@gmail.com. So dr.yang.uro. Yes, dot uro@gmail.com. So that's my email. So anyone is very welcome to email me for anything else. Thank you. Okay. Okay, you have a great day and stay safe, stay healthy, and I hope to see everybody you hopefully in the future. Bye. Thank you for the other background staff that's helping us. Bye.